Welcome everybody to this observatory seminar on backlogs. Cases of COVID are rising again, and sadly our health systems face familiar pressures as staff fall sick and patients with existing conditions are infected with all the disruption that entails. The scale of these challenges may be relatively small for now, but they add further complexity at a time when our health systems are only just coming to terms with the existing backlog. We know that COVID caused significant disruptions and delays in diagnosis and treatment, and it seems it may continue to do so for months and years. But what we want to address today is the evidence on how health systems and services can understand the issues around backlog and formulate supply and demand-side approaches to catching up, to securing the access that's so key to universal health coverage and to good health outcomes. This webinar will showcase a brief that's just been published, addressing backlogs and managing waiting lists during and beyond the COVID-19 pandemic. It's part of the Observatory series, but it was developed with WHO Europe and with the Nuffield Foundation. It helps define the nature of the problem and broad strategies on workforce, on managing productivity, capacity and demand, and on investing in infrastructure and models of care, the strategies we need to overcome backlog challenges. The brief also sets out an inventory of policies that show what practical steps are being taken, can be taken, that have practical use. So the webinar, which is being recorded, we'll hear from a very distinguished team: Hans Kluger, the WHO Regional Director for Europe, who sent us a video recording, Eva Bachiniken, Coordinator of the Observatory's Berlin Hub, Natasha Asabadi-Muscat, who's Director of Country Health Policies and Services at the WHO European Regional Office, Ben Jupp, who's Director of Strategy at NHS England, and Pascal Gorel, the CEO of the European Hospital Federation. We also hope, though, to hear from you, and we've set aside, as always, a substantial chunk of time for your questions to be discussed. Please would you put your ideas and your questions into the chat, which my colleague Erica Richardson will monitor. Towards the end of the session, Erica will also be running a poll. For us, this is an introductory session on backlog, a really important topic, and we hope you'll help us to shape some of the follow-up sessions that we plan for the autumn. So let's begin with the overview of backlogs and with some opening remarks from WHO Regional Director Hans Kluger. Lucy, could you run the video? Thanks.
Dear colleagues and friends, for nearly 2.5 years, the COVID-19 pandemic has stretched health systems and limited their ability to provide care when and where needed for all people. We all know that while countries in our region have some of the strongest health systems in the world, not a single one was fully prepared nor resilient enough to tackle the wide-ranging impacts of this emergency. A major concern since the onset of the pandemic has been the pandemic's impact on countries' capacity to maintain essential healthcare. In 2020, over 90% of countries in the WHO European region reported some disruption to essential health services. At the end of 2021, a 23-country survey indicated similar levels of disruption. This underlines that our health systems continue to face the dual challenge of managing both COVID-19 and disruption to non-COVID-19 services, leading to growing backlogs and waiting lists. For each person who cannot receive care when needed, this delay may have severe consequences, from worsening health problems, prolonged recovery, and decreased quality of life. In order to restore services to pre-pandemic levels and catch up on care, we need to understand and act on what we have learned from the pandemic, including investing in the health workforce, increasing funding for a future health infrastructure, and maintaining the innovative forms of service delivery that proved useful in reaching out to key groups affected by the pandemic. The policy brief we are launching today is a very valuable resource for policymakers seeking to understand the extent of disruption to health services caused by COVID-19, the reasons and especially how to respond. Its aim is to provide options to reduce service backlogs in different national contexts. It is a very important contribution to our ultimate goal, as laid out in the European Programme of Work 2020-2025, to provide better services that deliver more efficient, people-centered, high-quality care for all. WHO will continue monitoring the extent to which health services are disrupted, maintained and restored due to COVID-19, particularly regarding recovery efforts and how to strengthen health systems across Europe and Central Asia. We will also keep working with countries on how to clear backlogs that have piled up in the past couple of years. My warm thanks to the experts and partner organizations who have contributed to this timely policy brief. This launch marks a significant step to make sure that our health systems emerge from this health crisis stronger than before. Thank you.
I think, not sure what the etiquette is on thanking a video, but really useful to hear from Hans on the importance of getting back to pre-pandemic levels and on the role of workforce funding and innovation and how we actually address the backlog. So Eva, I'm going to come to you now and ask you, please, if you could give us an overview of some of the content of the brief. Thanks.
Yes, this will really be just an overview because it's very rich and very packed. So we intend to plan some more sessions later on. After the summer break with more time, more detail. But first, let me start by thanking my co-authors. This was a wonderful collaboration with Sarah Reed, Luigi Siciliani, Astrid Eriksen, Laura Schlepper, Florian Tille and Thomas Zapata of the NAFI Trust, the World Health Organization, and some of the team in Berlin from the European Observatory on Health Systems and Policies. So let me start by giving a little bit of background. We all know that in early 2020, health systems began to postpone non-emergency procedures to keep capacity available for COVID-19 patients. This obviously has led to much longer waiting lists. These are just the numbers of people on the waiting list, which in itself is not a problem, but the real problem are the waiting times. The amount of time that people will have to wait before they receive care. And additional cumulated number of patients on the waiting list we refer to as the care backlog. And this is an urgent challenge and problem because each delay in diagnosis and treatment may worsen health prospects. And we're receiving more data that this is already the case, thinking of mortality data, life expectancy, etc. What do we know about service disruption and backlog? Services were disrupted in virtually all European countries. We've looked at national data, international reports. We have the pulse survey of the WHO. Several publications all point to the same conclusion, that although it really also started in hospital, dental and mental health services, it really also started to spread out towards primary care and emergency care. And although the disruptions decreased somewhat, towards the end of 2021, which was not the case for all services, it is a spreading problem affecting the system as a whole. The fact that not all countries systematically monitor waiting times is a huge challenge here. And then you need to look at other numbers like utilization numbers or hospital admissions, for example. And then we have the problem of the missing patients. Those are patients who were expected to be referred for treatment, but did not present during the pandemic. Numbers, for example, from England is that this number is somewhere between 7.5 and 9 million people. So a case in point is an illustrative figure, is this figure here. That shows the extent of service disruptions in several areas. And you see, for example, that for cancer care and nutrition, this number was still increasing, whereas for some others it was declining somewhat, but it's affecting the system as a whole. And these disruptions, of course, have led to a high number and higher unmet need of care. Over a fifth of the EU citizens have missed a medical examination or treatment. Those are incredibly high numbers. If you also look at the number of people or the percentage of unmet need, 47% reported hospital or specialist care unmet need, which is staggering numbers. At this time, probably lower, but it's still something that just shows the incredible challenge we're facing here. So what are the drivers of the backlog? What is causing this backlog? We have supply determinants and demand determinants. We have some that increase the backlog, and there you can think of a system that is not well prepared in the sense that it has low numbers of health workers. We also have the cost of providing treatment that has gone up. We have the additional problem of staff exhaustion and burnout, which is really a huge challenge, arguably the largest challenge facing us. Also, payment systems were changed during the pandemic. And in a way, they prioritized COVID care over backlog care. And we need to also see how we change that situation. Then we have a whole host of factors that were already there, like aging and rising chronic conditions. Although long COVID is a new chronic condition where we still don't know what the effect is going to be, the impact long term. Then we have increasing expectations, new technologies and treatments can lead to new demand for care. And we have a higher demand for healthcare because of the COVID-19 patients, but we also can have unforeseen shocks in the future. Decrease of backlog, the factors that decrease backlog can be having already a system in place that is well staffed, available workforce, a large infrastructure, higher financial capacity. Technologies can also play a role in mitigating the backlog. And then we have the fear of infection, which also is leading to a decrease in backlog, but that is not a positive one, but obviously it is going to lead to an unmet need in the future. So bringing care back to previous levels before the pandemic will not be enough to overcome the backlogs. We have pre-pandemic waiting times that are quite severe in several countries, and that number only started to increase during the pandemic. As you see in the figure here, the pink part of the graph is the accumulated backlog, and you can see if you look at the y-axis that the waiting lists are then, of course, increasing. If we then resume care to the previous levels, then you are in scenario B, which we listed here as B. It will bring down the waiting list somewhat, but it will lead to a permanent increase of the waiting list. It would be better if we have scenario C or D. C is a temporary strong increase in supply, and D is a permanent increase in supply. Depending on the county context, these are the scenarios that we should try to follow. So which are the policies that countries have been using to tackle the backlogs? And we see three broad strategies: increasing the supply of workforce and staffing, improving productivity, capacity management, and demand management. Those two are perhaps more short to midterm. And then we have a longer term strategy that we see that is really investing in capital infrastructure and new community-based models of care. So just very briefly, they are discussed in large detail in the brief itself. Increasing the supply or workforce and staffing. You can think of introducing new professional roles and scoping widening the scope of authority, flexible recruitment and training, even some countries looking at international recruitment, which also has an ethical component that we should look at. Very important, improving work conditions and offering mental support, really helping the workforce and preventing them from work burnout. And that also includes helping them in their daily life and making life a little bit easier with simple things as free childcare, parking, and transport. Improving compensation is something that many countries have done, which was well deserved, but it's not going to solve the long-term problem here, and it will not prevent people from having a burnout or becoming really exhausted. So for the second main strategy, you can think of separating planned and unplanned care, which we have seen a lot as an effective strategy, freeing more acute capacity outside hospitals, enable better separation of emergency and routine patients, extending the hours of care, although also here you need to very carefully assess how you're going to do this with your available staff and you don't overburden them. Expanding access to telehealth services and virtual models of care is something that probably has been talked about the most as a solution for backlog. But I think that there are still many unanswered questions in what parts of the health system can we apply these and that they are effective, and how do we prevent them from increasing inequalities? Important questions that we need to address in the future. Implementing demand-side prioritization policies is also something that many countries are trying to do, and we can really learn from each other. Having a more stringent prioritization mechanism in place could prevent people to come on the waiting list who have little or no expected benefits from treatment. So lastly, which we really saw very clearly during the pandemic itself with COVID patients, that by better spreading patients across available capacity, you can actually gain a lot. So some of those mechanisms that were installed during the pandemic can also be used for backlog care. Countries can spread patients much better over available capacity, but also perhaps potentially abroad. And there are European mechanisms that can help facilitate this. So then the more longer term perspective would be investing in capital infrastructure and new community-based models of care. This, of course, also requires upgrading health infrastructure and facilities. And it's really all aimed at investing in primary and community care, in home care, aimed at preventing people from going to the hospital or unnecessary admissions. And here, of course, digital infrastructure can be of great help. And in some countries, this still needs to be built up. And there are many ways visible already in some of the countries that you can do this with virtual ways of working. This, of course, also needs a lot of resources. So a conclusion, maybe implications for policymakers. I think we all agree that clearing backlogs is critical for maintaining health gains achieved before the pandemic and avoiding higher mortality. As I said before, we're already seeing the negative impact in terms of mortality. A key requirement is the systematic collection of reliable and meaningful waiting time data, which some countries are still not doing. So I think here we can gain a lot, and we will organize a webinar on this issue after summer. Policies to support and protect health workers should be prioritized. We cannot do this without workforce, and this is perhaps the biggest challenge in front of us. But many countries don't have decent, appropriate workforce planning, and availability of staff remains inadequate in many countries. The issue of increasing inequalities is a challenge that we need to look at, not just because of the new technological solutions that may not be accessible for more vulnerable people or difficult to access. But also countries should make therefore really strong case for reforms and investment. This is the moment to address these long-standing gaps and inefficiencies and inequalities in the health system. Lastly, for more information, of course, read our brief. That's the first. We also just have published a health policy special issue, learning from the COVID-19 pandemic. We have a whole book, a whole study on lessons for learning, for building back better after the COVID-19 pandemic. And our colleagues from the NAFU Trust published a good report on health system recovery that also contains lots of useful information. If you sign up for future webinars, you can do that through this tiny URL. I'm sure that will also be provided in the chat. Thank you very much.
Thank you. As you said, and it's an incredibly rich brief with that message that provision, taking it back to previous levels isn't enough. And then the threats of how you actually do that in terms of the burnout of staff, the access, the equity of access of technology. Go now, I think, to Natasha, who is the Division of Director of the Division of Country Health Policies and Systems. Natasha, I think to give us that sense of the sort of European perspective overall on how countries can begin to go about addressing these challenges.
Thank you, Susie, and thank you, Ewout, for the presentation, but also for the great collaboration. And indeed, I think what we are discussing today is no small matter at all. Beyond upending our lives as we knew them before, the pandemic has dramatically changed the health system landscape, and you made reference through this also by explaining how payment models have been changed in some countries, and unfortunately not always for the better. And I'd like to underline that hospitals, primary care facilities and health workers have gone beyond the call of duty during the most critical months of the pandemic. Yet, despite this, patients across the board have seen their non-emergency needs pushed to the back burner. And this has resulted in backlogs, in delays and waiting lists that have fundamentally prevented and stopped people from getting the care they need in a timely manner. And so for me, this brief has some really important lessons that we need to take into account as we seek to build more resilient and stronger health systems, and health systems that are better prepared for the next shock. Because one of the things that worries us also as WHO is that sometimes we ask ourselves, would health systems be actually better prepared to withstand a shock? Or are they actually still very much on their knees and reeling and quite struggling to get back to where they were even before the pandemic, when we want them to be in a stronger place? So a few key lessons that I would like to share. First, we know that there is no resilience and no preparedness if we don't invest in our health systems up front, and I mean real investment. And the only way for these backlogs to become a past memory is if we put all our efforts together, because it's not an easy, it's a complex task that we have ahead of us. From our health workforce to service delivery, we really need strategic decisions and investment, and we need them now. Without this, sadly, the waiting list and backlogs will only continue to grow, because in fact, these are actually a dynamic and not a static phenomenon. The bad news is that they can regress. The good news is that they can change depending on how we react and how quickly we can actually create the right solutions. But of course, one prerequisite for this is the systematic collection of reliable data. And unfortunately, we see that in far too many countries, this is still not the case. But maybe most importantly, our window of opportunity for placing investment in health systems at the top of the agenda is closing rapidly. Why? Because we have to understand that at the moment, countries continue to tackle a range of other crises at the same time, crises that are shifting their energy and resources to other pressing matters, such as defense spending, because we do have a war raging in the WHO European region, as well as the management of inflation and rising costs of living. And of course, financial resources are not infinite, and the time therefore to act to ensure that health system investment remains at the top of the agenda is now, and tackling this problem really requires investment. The second lesson is clearly that we do need better data across the region. What is not measured is not visible. It is that simple. We need to know where the problem lies, in which areas, in which sectors, in which specialties, how large the problem is it growing bigger, is it growing smaller, and so on. And of course, during the pandemic, we have seen stepping up of initiatives, for example, with improvement of disease surveillance data, with some very good systems being set up to monitor vaccination uptake. So this shows that it is possible to make progress. And third, we must not underestimate the role of the health workforce. And in September, we will issue a regional flagship report on this matter, because this is really the critical issue, as Ewout has mentioned. Finally, let us not forget the potential of digitalization in helping us perhaps to do better, to understand better how we can improve our efficiencies, and also in order to find ways in which we can, for example, sift, reach out and use our resources more effectively. So I'll stop here for now and rest with these three messages for starters. Back to you, Susie.
Natasha, thank you so much. I think, you know, the message about investment and the competition for focus for policymakers in other sectors and other demands is so important. And as you say, data, so we can demonstrate what's happening, the workforce and digital. I know that Ben is going to pick up on some of the uses of digital to talk to governments, and that Pascal will come back to us afterwards with more thinking on workforce. So if we could go now, please, to Ben Jupp, who's the Director of NHS Strategy in England. Ben, over to you. Thanks.
Great, thank you very much, and it's great to join this gathering today. I think there's just one slide of mine which is going to come up. Maybe we can just put that on full screen for people to be able to see it a bit more easily. So we've got both as ongoing challenges. We've got about 11,000 people in hospitals in England which are COVID positive at the moment, and a series of other challenges, and some significant kind of capacity and backlog challenges. One thing we are very lucky for in the NHS is in terms of our data on waiting lists, waiting times, and a number of other factors as a unified national health system. So we have seen the total waiting list for diagnostics and planned procedures increase by a bit more than a third since before the pandemic, from 4 million or so people to 6.5 million people on our combined waiting lists. As Ewout said, a lot of people go through our health system every day, so it's not necessarily the size per se, but the waiting times that flow from that. And we have a target of treatment from first point of referral of a maximum of 18 weeks historically in the NHS for the majority of procedures. At the moment, we have significantly longer waiting times. We have about 300,000 people who've been waiting more than a year, which is obviously not where we want to be at all, and just reflects the scale of disruption from the pandemic. I would just pick out 4 things which are at our heart of our response. So firstly, we do need to increase capacity, that is workforce. It is also the number of beds, it's the amount of virtual wards and hospital at home services, and it's making better use of the independent sector as well. Secondly, as we increase capacity, we want to get better at the way that we are delivering care, working with patients, and our kind of prioritization approaches. So there's been a lot of collaboration during the pandemic in terms of emergency responses, and we want to kind of continue that collaboration in terms of addressing backlogs. So that is in terms of some sharing of waiting lists, management of referrals across areas. That's supported by the development of integrated care systems, which went on a statutory basis just from last Friday in England. In terms of transforming the way that we provide care, I think at the heart of our approach is around some further separation between planned and emergency pathways. A number of countries have probably greater historical separation than we do in England, and it just helps in terms of that resilience that we heard about. So in particular, developing surgical hubs for sub-regions and areas, expanding diagnostic facilities, but particularly bring them out of hospital into community diagnostic centres. And then finally, around the relationship with patients. Some of that being enabled by technology, as we talked about before. So giving people better information about their waiting, giving them more control in terms of managing and booking appointments. And for example, around outpatients, a model in which we move somewhat away from kind of routine follow-up outpatient care into more tailored follow-up outpatient care, which is, we hope, better for patients, but also frees up capacity in the system as a whole. I think I'll stop there because we want some time for discussion, but I hope that's a useful little snapshot, and it's really recommend the report as well.
Been really useful to see both the sort of innovation that you're trying to take the opportunity of COVID to push new models, and the sense that addressing issues which are long-standing issues like integration and sharing of patients and priorities. I think now if we go to Pascal Gorel, who is the CEO of the International European Passports Federation, sorry Pascal, we will get to hear a little bit sort of some of the risks involved for the workforce and for patient safety. Pascal, over to you.
Thanks a lot, Susie. Thanks a lot for the invitation. Very honored also to have reviewed this excellent policy brief. Congratulations for the work. It's really a good piece for discussion and debate, so I won't take also too much time so that we can have a first discussion today. To build on what has been said already by previous speaker, a few things. From the providers side, hospitals and healthcare services, we represent both sectors, sometimes the same one. First, on availability of data, it's clear, and it's very nice you're doing another episode of webinars on waiting lists, because yes, there are still countries without knowledge about actually the backlogs and the waiting times. So it's not only the availability of data, but it's also the quality of data. Remember the discussions we had, or we couldn't have at the start of the pandemic concerning the ICU bed numbers, because we don't have the same indicators, we don't have the same rules. I know Technical University of Berlin did a lot of work with Reinhard Büsser on this, so it's very nice. And the observatory in general has been providing a lot of useful information for providers during the COVID period, and that's really should be mentioned, because you did work in the economic and financial crisis before, but here this time you were really ahead of everybody to provide us information. It's not easy to capture the diversity of situations, because we had different ways. We had different ways at a different time. The situation of countries were extremely diverse at the beginning. Important variation state during the COVID. So it's important, and I also emphasize in this paper, it's quite clear that it's important. So I want to focus on two things already mentioned for the first one, which is the workforce. Again, we have an issue of data, availability and quality of data. There was this project Prometheus in the past that tried to look at flows, and they discovered that actually there is no workforce planning in most countries because there is no information to be able to do workforce planning, and we're still there. So we get feedback also on the difficulties of recruitment and retention, but sometimes without any accurate and available figures. And so that's a very important element that is important for the future if we want to be more ready in the future. What is important also in these 2 years we lived, there was something new, very important for recruitment and retention. As you know, in many countries, we had already difficulties to attract and keep professional, but this time there has been an additional factor, which is the risk for the workforce, and extremely visible in the first waves in a few countries. But then this message gets along everywhere at the end, and the number of death among healthcare professionals is an important element to remind in also the strategy to get people back or to try to get new generation to work on this. We've had this a very long time ago experience when the HIV arrives as a new disease in hospitals, but this time it's much more significant in terms of influence on the perception of professionals have on their work. So sociologists have been working for long on difficulties to recruit and retain professionals. There is now this additional element. And then I would like to finish on another element that has been not so much, unfortunately, it's mentioned during the COVID, is patient safety and quality. And it's nice also that WHO Europe has been opening a new office to work on this because yeah, again, it was rather absent of the picture. And interestingly, we did a webinar recently on presenting the French survey, a 10-year survey. So they did a survey in 2009 and a new one in 2019. And interestingly, on this survey on severe adverse events, they were giving examples of progression on patient safety in France, but unfortunately, in the one sector that was mentioned in 2019 as a survey as problematic was the ICU sector. So here again, we need more data. We need more data of good quality to be able also to compare. So I think it's a next step also for this kind of survey. And to conclude on the pre-pandemic situation on diagnosis and treatment should not be considered as optimal, clearly, because it was not optimal in many countries. And again, it's a starting point, I guess, for more discussion. Thank you.
Pascal, thanks very much. I think, you know, that sense that we're not just talking about the data on waiting lists, the data on the people, the data on the issues and the problems and the interconnection, because clearly patient safety, if you have a workforce that's burnt out and overstretched, has huge implications for patients too. I think that we know it's want to thank all of the speakers for very short and very clear presentations and highlighting that the risks are not just in terms of health, but to the system, to the staff. If all of the panel, you could put your videos on. I think we'll go to Erica now, please. Just if we could, to get you a sense of some of the concerns that the participants are sharing at the moment.
Thank you very much. Yes, quite a busy chat box, which is lovely. Lucy, could you just launch the poll? I'm going to quickly take this opportunity while I'm summarising what's been happening in the chat box to ask you if there are any aspects of the backlog that you're particularly interested in, so that we can potentially revisit them in the autumn. So, you know, given the importance of backlogs and the increasing waiting times, which policies would you like to learn more about? So increasing the health workforce, supporting the current health workforce, improving productivity of the health system, capacity and demand management, investing to upgrade infrastructure and facilities, or new models of care. So yes, just let me know your thoughts and we'll reflect on those afterwards. So from the chat boxes, there's a lot of people who've been talking about the pressure on the health workforce and what the recommendations might be, or what people feel about how we're going to deal with recruitment problems, how we're going to look after the workforce we have currently to prevent burnout. And a very interesting questions come in about the potential health system shock of increasing energy costs, and how that plays into, you know, we're going to be using more energy because we've got to clear the backlog. And is this going to be something that's really going to overburden the system? So your thoughts on that would be particularly interesting as well. Thank you very much.
Erica, thanks. I think perhaps what we ought to do first is have a little bit more thinking about some of the workforce issues. And I don't know who wants to start, but it seems that there is clearly a focus here on supporting the staff. But I think we were talking about digital, what are the implications for wanting to shift the way we deliver care and shift the settings of care. But also, I don't know, Natasha, if you want to speak about it in this round or in a subsequent round. Clearly, one of the problems in Europe is that there is a tendency to recruit from the east to the west. And when we have shortages across the region, I'm interested to hear from any of the panelists. So Natasha, I'll come to you first, and then Ben and Pascal, if you could be on standby, and Arat, thanks. Natasha, over to you.
Thank you, Susie. Let me just start by saying that every country across the region, whole 53 countries, have really placed workforce shortages as the most difficult policy issue they are struggling with at the moment. This was very evident a couple of months ago when we had our small countries meeting. Why? Because the small countries also, they lose their workforce to larger countries, and you have raised the salient issue about east to west migration. It actually goes beyond that. We see that in a number of European countries, there is now an increasing reliance on health workers that come from outside the European region. And I think what we are seeing really is that Europe has an aging population. Everybody knows that. But in many of our countries, we also have a very rapidly aging health workforce. We're talking about a median age, for example, of the health workforce in some countries of 55 years, particularly for nursing, particularly for primary care. We see a huge divide also amongst the urban rural. So one needs to start to dig deeper, because you tend to find that whilst all countries, irrespective of their wealth or their geography, have a problem, you start to dig deeper and you find that this is also a very uneven problem. So for example, if we hope to give some respite to hospitals by empowering primary care to do more, and we find that we just don't have the workforce that we need in primary care, then the policies may look nice on paper, but they cannot be implemented in practice. We also made some very concrete recommendations around mental health. We believe that every health facility needs to have a mental health focal point for our health workforce. Let's not underestimate the impact of stigma in actually accessing mental health services when you are a professional working within that community and you need then to actually access services. So we need to create dedicated streams also for our health workforce to be able to access the mental care and support they need before they become exhausted, before they burn out. And with digitalization, Susie, I think the yardstick that we are talking about is that digitalization must work for the providers, for the professionals, for patients, rather than introduce an additional administrative burden. I'll stop here, there's so much to say.
Pascal, do you want to jump in from the position of the hospital perspective, since clearly...
Sure. On this issue, we actually submitted our position in a recent call from the European Union. We are very much European Union centric. We don't cover all the WHO Europe countries. But what we say, to be honest, the European legislation on mutual recognition, it's very nice tool, but has been a beautiful tool for brain drain. And that's a big issue. That's a specific EU issues, but again, it's 27 countries. It was 28, and it facilitated a lot of migration also to the UK. So that's something clear. But there's something else also in addition, which is the brain drains within the countries. We have medical deserts in Germany. We have medical deserts in France, in Spain, in Romania. And that's something not related to migration between countries, but within countries itself. So it's an additional issue we have to tackle. And there's no silver bullet for all of this. We've been working for this for more than 20 years, honestly, because of course we knew the population was aging. We knew our workforce was aging, but we've seen a part in the crisis period, economic crisis period, we've seen people leaving the profession in quite significant number, in particular in the nursing workforce. And we are afraid that it's going to be even worse with this COVID and post-COVID time. So yeah, it's a worrying situation for all of us. At the same time, we have changed the way in many countries that we organize things, like think about day surgery, for example. We don't have people 24 hours, 7 days a week. And that's where in the proposal of the in the policy brief, there are, of course, some contradictions. If you extend hours of care, you said it, where's the work-life balance? How can you keep people? So I think organization could be a way, one of the way to try to improve the situation, but it will not solve it all.
Thanks, Pascal. Ben, I don't want to put you on the spot, but do you want to come in on anything particularly on support to workforce mental health or other?
So I think I'm sure it's the same in systems across the world. I mean, the retention challenge is the one that is the one we face most urgently. And actually, interestingly, we saw retention stay higher during the pandemic for various reasons and people's commitment. And so the short-term question is how we can put in place the variety of kind of support and flexibility, sense of agency in the workforce being involved in recovery and the ongoing challenges. And then, of course, in the medium and long term, it is about our kind of wider training and recruitment pipeline. And I think across the world, we're seeing further reflections on new roles as well. So to come to your point, Susie, about resilience at the beginning, how do we make sure we have the more flexible and generalist roles as well as specialist roles, which will be required overall, but particular for future shocks?
Thanks. Erica, I'm not really planning to do a round on the cost of energies because I know that John Silas took a look at whether the energy costs and shifting energy costs were going to have a huge impact in the short term. And it seems that as a share, one, there's not a lot of evidence, and a share of overall spending, it didn't seem to be hugely significant. But I did wonder if we ought to go back a little bit on digital when, Tasha, you specifically said that it was very important to ensure that these innovations are not an increasing burden to staff and don't create just extra work and tailored to them. I wondered also whether we wanted to have a think about whether the implications for patients and the equity dimensions of introducing digital, given some of the unevenness that we've got. Eva, do you want to have a quick response on that, and then we'll go around?
No, I think that often digital solutions have been served as the magic bullet, and I think that we have to push back a little bit there. I mean, the potential is enormous, but sometimes we still need to evaluate these policies and that they also benefit people who need it most and whether vulnerable people can access them. So I still think that there are so many questions that are unanswered here and that we need to carefully look at.
Thanks, Eva. Ben.
So I would see some very positive developments and some things which we all need to think about. So on the positive side, just the number of staff and patients who've experienced some sort of digital enhancement to their care is very high on the back of the COVID vaccine app, for example, vaccination status and other things. We now have more than half the adult population in England having the NHS app, which is an incredibly powerful way to be organising appointments, sharing information and the like. I think the experience I've seen from around the world is that processes which were acceptable to clinicians and to patients during the pandemic, even if they were a bit clunky, are not necessarily acceptable as we come out of that. And so the bar for the simple, accessible approach, particularly for busy clinicians and for patients, is going to need to be higher than it was during the pandemic.
Thanks, Ben. Natasha.
Thank you. So I think what we have noticed during the pandemic is that digitalization has really been accelerated. And we now say that multimodal care is here to stay. Many times, however, digitalization was very much associated with hospitals. And I think the innovation that we see now is digitalization more in primary care, in the community. And we very much hope that this could start providing some kind of solutions, particularly by linking remote areas and remote facilities to the urban centers, to the hospitals, and to ensure that we backstop and provide quality of care. So of course, it is not a magic bullet, but if done well, if done after we ask the right questions, which is not just, I want to throw a bucket load of money into digitalization because it is a priority, but I'm going to invest in digitalization because I want to use it to reach areas that I cannot reach, then we start having a conversation. Of course, there is no hiding from the fact that in healthcare, we have this inverse situation where the people who need us most are often the ones who are least literate and least digitally literate. But we need to turn this challenge into something that we embrace head on, because at the end of the day, people who are immobile, the older persons who are stuck in their homes, the people who belong to rural populations are the ones who could stand to benefit the most from digitalization if we equip them with the right technology and with the skills, the competence, and the confidence to use it.
Thank you, Natasha. I think, that does begin to address also and speak to Pascal's real concerns about the disparities within countries as well as between countries. Erica, have we got time for another round of questions? Is there a couple of issues you want to flag?
Very quick round, maybe. Just there's been a little bit of talk about, obviously most of it's been about the health workforce, recruitment, training, those are the big issues. But also there's been some interesting ideas around the potential for increasing efficiency and capacity by using things like cross-border care. Is that something that's been explored within the European context? But also a real emphasis on diagnostics and improving access to diagnostics and not just elective surgery. So yes, just that's all that's been coming up.
Thanks, Erica. From our panel, any volunteers that want to go first on that one? I know, Ben, that you were suggesting that the UK is not the most community diagnostic based. Eva, I thought I saw your...
Yeah, just to the point of cross-border care, because I brought it up.
Yeah.
The potential is there. It's not really used a lot. I mean, it's also not everywhere it's a solution, but think, for example, of how Germany was treating more than 300 foreign ICU and COVID patients or from abroad, from France, from the Netherlands. And so it is possible, even with these very complex patients. So this is something we should look at. I don't know why we shouldn't. If the capacity is across the border, you'd be crazy not to look into that and use the European mechanisms. I think somebody asked, what are those European mechanisms? We have them, where you can use them, to pay, and it's all arranged. So it's just a matter of, linking up with each other and using those opportunities.
Thank you, Ben. And Pascal,
just on the community diagnostics point, I think that this is partly out of necessity. I mean, some of our diagnostic pinch points are the ones which are proving hardest to overcome in our overall backlog and waiting list management. So there's a lot of focus into that, including new equipment. But I think it is just an example of how, as we build back, we can think differently, and we can use that to draw on the best of a learning on both of the kind of digital side and care, which is closer to home. And there's a variety of other aspects on that, from kind of virtual wards to telehealth more generally. So I'm actually quite optimistic that if we do this in a measured way, if we also manage to get the workforce and the other components alongside these service developments, we can actually be in a better position than we went into the pandemic in a few years' time.
Thank you. Pascal, I think I saw you wanting to...
I wanted to react to what Ewout said, because it's an interesting topic, an issue we should evaluate a little more, because I've not seen very good evidence about what happened, what you mentioned, the 300 patients and so on, which is a very, very small number. But this morning, I just found out the survey in France of transferring patients within the country. which is also one option. Interesting. And there's this scientific article that gives some evidence on this. So I think it's a fascinating thing, yeah, because there has always been this idea, at least in the EU, that why not sending patients where there are empty beds? I don't think that's the solution as a provider, but it's worth discussing it, so that patients don't have illusions also about what is possible and what is useful for them in terms of quality of care.
Thanks, Pascal. I'm very conscious that we're running out of time, but that what we've got is that sense of there are different innovative ways of trying to do things, and all of those require investment at a time perhaps when the suggestion is that the attention of policymakers is shifting elsewhere, that having overcome the pandemic and health having had resources, maybe now it's somebody else's turn. And I think we're hearing from all of you that if we're going to not just go back to what was not quite adequate before, but to do better, we need some serious investment that looks at new ways of doing things, that demonstrates efficiency, that new models, the things that perhaps were blocked beforehand, that now there is an opening to do something in a different way, is going to be so important. And perhaps just as a sort of closing reflection, before I ask Eva to conclude, demonstrating these new ways of thinking, of innovating, as are more efficient, will be one of the tools we can use to demonstrate that health is a good investment, not just because it's so important, but because it's actually getting its act together, and that this will be money and resources well invested. Before I ask Eva, do you want to do, Natasha, Pascal, Ben, anything that you need to say before we wind up?
Just very briefly, Susie, to mention the multidisciplinary team and the fact that we need to think a little bit more broadly also about what the health workforce should look like, and this in a way ties to how we make it more attractive to the new generation, a generation that has been brought up in a different context, that is far more digitally literate. So that's one aspect. And then secondly, just really to thank all the persons who have been involved in working to take this forward from WHO office. And here particularly, I'd like to thank Thomas Zapata, and also from the observatory team. And I think that there is really a lot to unpack in this publication, because we are touching upon the symptom, and we can dig beneath the symptom, so to say.
Thank you, Natasha. Eva, do you desperately want the last 30 seconds, or shall I let Natasha have that?
Yeah, no, it actually,
okay.
what Natasha was saying fits exactly what I was thinking as well. This is touching upon the issues, and we, as also research community, we need to come up with solution and help, how we're going to make this digital transformation, and the workforce, how we're going to retain them, how we're going to attract new ones. I think we all agree, and that is fantastic, but now we need to go full force ahead and do this, and we will also be doing that ourselves, and also relying on the networks that we created, that I really do want to acknowledge here, the HSPM members, and also the HSRM, COVID-19 response monitor people, because all of their findings, all of their observations that they have so meticulously recorded, also led to this policy brief. So big thank you, and let's work on the challenges ahead.
Eva, thank you. I echo all your thanks to the HSPM network and the HSRM network, but also to everybody who's been involved in the brief, and everybody today. Thank you, presenters, so much for all your time, and thank you everybody who's attended. The webinar will be available on YouTube shortly with the other observatory webinars, and we're now going to have a small pause for the summer, but we do hope to see you in the autumn, and we encourage you to sign up to the mailing list so that you don't miss anything. And we will hopefully be able to take forward, using your poll and also your suggestions, some follow-up work, so that, as Eva said, there's both an analytical response, but also a real focus on what practical responses we might support. Many thanks, everybody. Over and out.